Good morning, all of you. I extend my warm welcome to all on World Health Day celebrations on the occasion of Swachhata Pakhwada. I request Director Madam, Dr. Gitanjali Sachdeva, to welcome our Chief Guest, Padma Shri Dr. Shashank Joshi, member of Maharashtra Task Force on COVID-19. Now, may I request Director Madam to present the welcome address?
Very good morning. It's really pleasure to have Dr. Shashank Joshi, Padma Shri, and Dr. Joshi, famous diabetologist and endocrinologist with us today. We thank you, Dr. Joshi, for accepting our invitation to be with us on this day of World Health Day, which we are celebrating today. I won't stand long between him and you. I would just say that we have been hearing about him every day during the pandemic, during all the ways. And you know about his contribution in curtailing the spread of COVID-19. And I would just say one thing. I was very skeptical about how this would be controlled in Mumbai, highly dense area, about the COVID-19 spread. But the way this COVID-19 task force managed curtailing the spread of COVID-19 in Mumbai, or let's say Maharashtra, was amazing. And I would like to really acknowledge the efforts put in by Dr. Joshi. So now it's over to Dr. Joshi, and we are just eagerly waiting to hear about your experiences when you were handling this pandemic. So thank you so much. So I would just hang up.
Thank you.
Thank you, ma'am. And now we will request Dr. Karna to give a brief introduction of our honorable chief guest, Dr. Joshi.
Thank you, Pallavi, and a very good morning to all of you, and happy World Health Day. And it's an honor, Dr. Joshi, to introduce you. And as Dr. Gitanjali already mentioned, he's an endocrinologist, a diabetologist, medical researcher, and prominent practitioner. He's a member of COVID-19 Task Force from Maharashtra State. Presently, he's a consultant endocrine and metabolic physician at Lilavati Hospital and Research Center, Mumbai. He has a noteworthy academic career, topping all the medical examinations with first rank and gold medal. MBBS from the Grant Medical College and Sir JJ Group of Hospitals. He did his MD in internal medicine and senior residency from our neighboring St. GS Medical College in KM Hospital. DM in endocrinology from the Grant Medical College and Sir JJ Group of Hospital. During his initial days in Lilavati Hospital, he collaborated with the legend, Dr. R.D. Lele, father of nuclear medicine in India, and the duo have accomplished several research projects in the field of diabetology and endocrinology by using radioimmunoassays. Recipient of the International Clinician Award, Healthcare Visionary of the Year, Fellow of American College of Endocrinology, American College of Physicians, Royal College of Physicians and Surgeons, Royal College of Physicians, Edinburgh, President of Indian Academy of Diabetes, and former President of Association of Physicians of India. A visiting clinician at the Mayo Clinic, member of the ICMR WHO Task Force for Management of Type 2 Diabetes, Director of Asian Health Clinic in Western Australia, with 30 books and more than 800 research publications to his credit, and editor of textbooks for medical students, and editor of prominent Indian journals, Indian Journal of Obesity, Indian Journal of Endocrinology and Metabolism, Indian Journal of Clinical Pharmacology and Therapeutics, founder and executive editor of Indian Journal of Critical Care Medicine. He is featured on Man Ki Baat with PM Modi, and his accolade has been published on the cover page of the famous book, A Nation to Protect, Leading India Through COVID Crisis by Priyam Gandhi Modi. May I invite you, Dr. Joshi?
Thank you, Dr. Madan. Deva, the director. All of you all. It's like a pleasure to be here after probably 2 decades in this institute. First of all, I want to congratulate each and every person in this audience which is listening to me virtually. Because I think if at all our response in COVID has been robust, it is because of all the scientists. I think every person in the care space and science space has contributed to the Indian response. And Indian response has been a mature one, and I think please put your hands together for all of you. I think because only one of them, which is sitting here listening to me, has contributed to this. So yesterday when I had to come here, I was in a dilemma whether I should talk extempore or should I have some slides. Then I called up Dr. Madan from here late night. I'll carry some slides and I'll do some science a little later. But she told me that tell us the story of the Indian COVID response, Maharashtra COVID response, Mumbai COVID response. So though I'm an endocrinologist and I work actively in endocrine areas like diabetes, thyroid, obesity, PCOS, before I became an endocrinologist, I used to work in HIV/AIDS and public health, where I was formally trained in this. And then, of course, we never knew in March of 2020 where we were headed. And that's the time actually I got a call from our current chief minister that, though we know that you are an endocrinologist, we are having some virus which we don't know. We don't know whether it's a real virus or a phony virus. And we are forming a task force and would like to join. I said, I don't think I want to join this family. But this is going to disrupt the country and disrupt the world. So I'm not giving a choice, you have to talk. So I joined them. We had 3 mandates. We were dealing with a predictably unpredictable virus. And even today, the virus is predictably unpredictable. Yesterday itself, we had to do a public space talk on something called as a recombinant XE variant. You must have all heard that. I was on all national channels, I was on NTTV, all that. Because, for a change, we are hearing scientists now. We are hearing people who represent science. So I can say that I had a role of a healthcare communicator for the government and administration. That's a very difficult task. If I tell Dr. Sanjeva to go and tell people, he will have to take so many NOCs. So it's not an easy task. But for the first time you saw, your director General Dr. Balram Madhav, friend of ours, Dr. Vinod Kaur. Science, you see what we have to congratulate both the government, the state and center. If they allowed scientists to talk to the media, they allowed doctors to talk to the media. People caring for people with diseases to talk to them. That the reason was because there was fear, there was unpredictability, and there was an unknown. So I think that uncertainty or unknown was the biggest challenge with COVID, which we had. So let me talk about Taja Khabar, that is yesterday. So on 22nd of February, there was a South African costume designer who came to India. She stayed in a western suburb hotel. I can't take the hotel for best reason because otherwise people will put it out this on YouTube. And she tested negative, fully vaccinated. In South Africa, they give the mRNA platform vaccine. And then got mild symptoms, flu-like symptoms, Omicron-like symptoms. Tested with RT-PCR again, tested positive. Recovered in 2 days with simple isolation, a little bit of paracetamol. The only drug which really if you live in symptomatic COVID, mild COVID, it's probably paracetamol. Nothing more than that. Everything else probably is anecdotal and it's all speculation. See, in COVID, evidence-based sometimes takes a backseat and anecdotes and speculations took a forefront. So, one has to, the reason science has had a victory over COVID, and I can't say COVID is over, is because of this. And then she went back, sort of. But the sample remained in the lab. And there is a nanopore which the Tata Foundation has donated to the Kasturba Hospital, the Delhi Shastri, the lead microbiologist, the collaborator here. And her sampling showed that out of the Mumbai city 238 samples, 236 samples were BA2, which is the predominant way. One sample was the BA1, BA2 recombinant. And one sample was the Kappa. Kappa was the original strain. Kappa was replaced by Delta. Delta was replaced by Omicron. Omicron initially was BA1. Very rapidly was replaced by BA2. So what we saw in Mumbai between mid-December to mid-January was BA2. What people are now seeing in China, in Hong Kong, in UK is all BA2. We have already had it. So we don't have a cause of alarm. That's why we are opened up. That's why I'm a little more confident talking without a little mask here, because there's some distance from everybody. And, we are a little more confident than before. So that's for sure. So obviously this recombinant, real science consortiums are there. We didn't have this 20 years back, 30 years back. So there is an Indian Science Consortium, which is called INSACOG. So the data was presented yesterday morning to INSACOG. The scientists there said that we would like to have another analysis and reanalyze the sample. So I'm sure there are a lot of scientists here, and a lot of people will say, no, this is a narrative by the government. They don't want to. This is a denial mode. That's not true. We know from the recombinants from HIV that recombinants can be more virulent but less transmissible. But the Omicron is more transmissible and less virulent. So there is a dichotomy. That's number one. Number two, the commonest cause of recombinants is contamination. You all work in labs. A lot of you are lab scientists, right here. I want to show off hands from all of you. How many of you have had COVID? So I would say 50%. And everybody is vaccinated. Anybody not vaccinated? Everybody vaccinated. So, there is at least 50% hybrid immunity. How many have not had a precautionary dose? Precautionary is the booster dose. Precautionary dose.
Third one.
Right. So people who actually got COVID, they already got their natural booster. That's hybrid immunity. So clearly this recombinant needs to be relooked at. The single sample, single isolate. We need to confirm beyond reasonable doubt whether that recombinant is XD or not. And which is why the government of India said we would reanalyze the sample, we'll relook at the sample and then. Secondly, the patient is predominantly mildly symptomatic or asymptomatic gone back and is an international traveler. It's not an Indian thing. But the media narrative built around yesterday morning was that this is arrived here, we are again, it's like doomsday predictions. So that fear factor prevails a lot. And now everything has opened up. I'm happy many of you all are masked here. Because this is a closed indoor environment. In a closed indoor environment, I think still masking needs to be done. So let me start with the story from March, April. March, April, the mandate given to task force was Mumbai is one of the highest population dense cities in the world. Population density. I sometimes am very jealous of ma'am, who's originally from Delhi. She's acclimatized to Mumbai. They are used to everything big. They have their own jameen and all. We stay in small little boxes. We live in a concrete jungle, ma'am. No, right? So Dr. Madar also probably knows that. That we live in concrete jungles and our population density is very high. Then second problem in Mumbai has high humidity because it's next to the sea. And that the least survival of the COVID virus or any RNA virus is between humidity of 40 and 60. And therefore, you see both the peaks which occurred in Mumbai were around April, March and April, the big peaks. First and second wave. The third wave is an outlier. Third wave is really an outlier. And at the time, Mumbai humidity touches sometimes 80, 90 also. So there's a link. See, the reason I'm saying that is today, 7th of April, is the World Health Day. This year's theme is to save the planet and look at climate and look at air, food, and water. If you look at the website of the World Health Organization, that's what they say. And the main thing is that narrative of WHO then was that there is no need of a mask. This is not airborne. This could be potentially airborne droplet. So initially, the narrative was different. Then they realized this is an airborne droplet. So the airborne droplet transmission to get accepted took a long time from science. And masking science also has been hugely debated. But now we know clearly that this is an airborne droplet virus. It's a small little RNA virus. Origins of the disease, we have Dr. Ganga Kekar on the origins theory. The first report from WHO is still not out of public domain. We clearly know that it is not a man-made virus. Probably it's a lab spillover accident which happened and it got into the community. That's how breakthrough infections can happen. That's how we can get pandemic. So that's very clear that it's a spillover accident. It's not man-made. It's not biological warfare. And the science told us this very clearly. If all scientists were not there across the world, and this has united the scientific world because of virtual medium. But I'm happy that I'm here physically. But one thing is very clear cut that we, as science community, whether it's practitioners of medicine or whether it's basic scientists, everybody worked under one platform with one agenda. I remember my conversation with ma'am on people who get vaccinated, how their immunity comes out. She was the first person to send me that paper. So, the research ideas which scientists like all of you all are there, gave for the pandemic, contributed to pandemic, ultimately led to a response. And that response ultimately accumulated to a public health response, which was a national response and global response. So one thing is clear cut that in the first wave we were losing people. We had a population dense place in Mumbai. We have local trains. We can't have social distancing in a place like Dharavi. And we had to chase the virus out of the country. And our hospitals like AEM and Sion were overflowed with patients. We were losing patients. So the first thing which we had to do is identify and create a score of the vulnerable groups or the comorbid groups. So that was my first task, to make a risk group. So 3-4 things came out that time. First was, who is vulnerable? Senior citizens, people above 50 or 60. So in India, hypertensives, diabetes, people with heart disease, people with any chronic disease of long duration or immunocompromised states, or transplant survivors. Those were the comorbidity or the vulnerable groups. And even today, that scores true. The Indian COVID risk score, you need to identify that even today, if somebody has to be scared of COVID, it is that vulnerable group which is not capable of mounting an immune response. I saw ma'am's department on the first floor, she is that innate immunity. But this is one group which can't mount an immune response. And that's the group which really needs that boosting, that vaccination. This young adult crowd, which is 50% not taken the extra dose, it's fine. I have not taken my extra dose too. Okay, so it's not, because we are all waiting for the science to evolve and we are not sure, because we are presumably about 60 and we don't have a comorbidity. Probably it may not be the best interest to do it. So we are not technically eligible, though we are into the healthcare profession, seeing people every day. So one thing is very clear cut that in that time, in Dharavi, we were losing people. So first thing was to identify this vulnerable group and filter them out. In Dharavi, though, I also remember that we didn't have RT-PCR testing lab facility across the country. It was being developed. So we didn't know who was positive, who was negative. And the COVID thermometer was pulse oximeter. So actually, we took pulse oximeters into Dharavi, which are slums, ensured that anybody whose saturation level was 95 did not have an underlying lung disease, they were taken to the PKC center. And they were observed there. And their tests were sent. Because at least we could save their lives. If somebody senior citizen, they were desaturating, they were moved out. Because that was the only way to do things. So we had to save lives. And they all had common toilets. That was the spotlight of transmission. So obviously the sanitation there and public health hygiene became the priority. Masking was still tough. Masking was not easy. Mumbai masking has been much better than the rest of the world. And Indian masking has been much better than the rest of the world, but masking was still tough that time. And then of course these like lockdown had workers. So remember that the lockdown was predominantly only for one reason. that our public health infrastructure was not geared up to handle a large crisis. So the transmission had to come down. So the reason the first wave had challenges is because we were dealing with an unpredictable virus. That was the ancestral Wuhan strain. And the problem was that in 85%, and I have some slides which I'll show you, 85% of the time, people were having mild or asymptomatic. And most people were recovering at home. Because those 15% which we had to identify were desaturated, independent whether they were vulnerable or not, and we had to put them in hospital and save their lives. Because once they desaturate, the body's exaggerated immune response was leading to a cytokine storm. And once that cytokine storm was started, it was very difficult to save someone and develop things. And the only thing which saved their lives was tone position, oxygen, and steroids. The biggest bugbear which was there then, the first wave, was we didn't have drugs. We were having, all repurposed drugs. It was like an old wine in new bottles. And we were using hydroxychloroquine. We were using doxycycline ivermectin. We were using, remdesivir was not available that time. We were using the drugs for HIV like lopinavir, itazovir. And those drugs were being used with the hope that they will be antiviral. And we didn't have time to generate good quality science. So most of the trials done then were adaptive trials. Adaptive trials. ICMR contributed in a big way because they got into diagnostics and recognition, and they also ensured that the TB diagnostic kits or the TB program were converted into COVID testing kits, and that transition occurred. That was the first wave. First wave, mortality was high. Identification of saving lives was the primary target, and restricting severe disease was the primary target, and we didn't have too much of our armamentarium with us in the first wave. Genomic sequencing was happening then also, but we didn't know too much about genomes. But wave in Mumbai got curtailed. It took us almost 4 or 5 months to curtail the wave. That wave left telltale marks. So recognition was tough, and therapeutics were limited. Infrastructure was built, and the only thing which probably saved Mumbai were three things. Probably the large jumbo facilities. They were a buffer for hospitals. Because I'm sure that during COVID time, most of you all have lived in the city. We didn't have beds. Because asymptomatic or mildly symptomatic, everybody wanted to occupy their near and dear one in the hospital. And everybody wanted to be in the hospital. So this jumbo facility became like a buffer for those intermediate patients who could desaturate and potentially deteriorate. Because we have very limited critical care facilities. Your biggest challenge in India today is that our healthcare infrastructure for our population was not commensurate to the population, the public health infrastructure, as well as the government infrastructure. Because 60 to 70% of our healthcare delivery is through private model. Private model is expensive. So the second thing which the government did, both state and central, is they capped the ceiling on the pricing so that it became affordable and accessible. I think the first thing they did was jumbo facilities so that there was a buffer. Second was, even if you had to go to a Lidavati or a Puja, couldn't get into a KM or science, you could go at a very affordable cost because the cost was capped. I think that was the second thing which was a saver for the city and the state. At least as far as Maharashtra is concerned, and most governments across India did the same. Because remember, health is a dual subject. It's a state and a center subject. Most of the policies came from ICMR. In fact, everything came from ICMR. You ask me, the RT-PCR threshold of 35 also came from ICMR. Everything came from ICMR. So ICMR has a huge role in COVID policy making. Much more than science and technology and everything. I must congratulate ICMR that they were persistent and clear in their vision. They never changed their mandate too often. In fact, even in the National Task Force, one of the members was from this institute, the member secretary was from this institute. And Dr. Sandar Ketkar was very actively involved in the formation of the task force. The DG ICMR was the co-chairman of the ICMR task force. They were very clear in their mandate that the model was minimalistic, it was evidence-based, and it was appropriate. That was the second thing which was important. One was jumbo facilities, second was capping of pricing. And third was probably the restrictions on movement in the first wave did help, the first 6 weeks, so that the spread was not very huge. It clearly made it. And by the time we understood the pattern better, so the clinicians, when we are battling with the unknown, we don't know what we are doing. Taking steroid. In fact, we started giving steroids in Mumbai and India much before the recovery trial was published from it. Or in UK, sorry. Because we were giving methylprednisolone. We realized that cytokine storm was very sudden. The only drug which can save cytokine storm was probably a methylprednisolone. So we didn't use dexamethasone, which was used in the trial. We used methylprednisolone for 5 days, and patient life was saved. And then we were using those immunological blockers, the monoclonal antibodies, which were like tocilizumab, eculizumab, and we were using those agents, and they were saving their life. But that was in a very small percentage because these were very expensive medicine. Antiviral space of remdesivir, favipiravir at that time. Favipiravir actually the repurposed drug from Japan. It's an anti-flu drug available only in Japan, in Russia, and India. Whatever happened, the Western narrative was not very kind. And I think India should be very proud of it. The West never scoffed on us because we could not generate evidence, but we delivered results. For per million population, we should be proud as Indians that probably the Indian output on COVID, we have had one of the lowest mortalities. Okay, that's a fact of life. So no question asked of it. The UK and US, so they said one thing, they go by evidence base. They did not have these strict mask mandates. There was a large anti-vaxxer population. And their response was they were waiting for evidence base to generate for them to do things. While I think the clinicians here did not wait for evidence base to generate. They wanted to save lives. So they used everything in the book to save lives. We recognize one feature. Most people with COVID used to die at night. Between 11 o'clock at night, 4 o'clock in the morning. So, I still remember talking to our municipal commissioner. I spoke to him yesterday also, Shashank. Every day I should talk to the HOD of AM and Science. Why these people are dying? We realized that COVID, most of the doctors were fully their shields like on down, it was very down. And patients wanted to get at night to go to the room. When they used to exert, they used to desaturate, they used to take out the oxygen, and they used to collapse and they used to die. So a simple technique was used that there was a bed commode kept there. And there was a nurse allocated who could visualize that patient does not remove the mask, the oxygen when the patient is going for a toilet. The toilet was right there. There was a bell kept there. And that reduced the mortality by more than 80%. See, ultimately, that's what matters. So these were all simple observations. If we are clinicians that we are doing, we observe. You look at our observations and do science based on research. There is no clinical observation. That was started to save life. And that was replicated across India. That this is what is happening. And what thermometer was oxygen. So first wave happened and people thought COVID is over. By November, December, people had again gone back to square one. People were not good. Had gone back to square one. People were, all in their own frame of mind. And farmers education started in Delhi. You must have heard that farmers education. So very big. So there were farmers from Vidarbha who had gone for it. And they came back from there. Now remember that in December, UK Genome Consortium announced the arrival of alpha. And north of India, particularly Punjab, Haryana, and Delhi, it's a very strong tie and wedding season in the December month. So a lot of alpha got imported from UK to India. And some of it went into the farmers, and some of that went to Vidarbha. And probably that is where probably Delta is born. Probably. Again, it's all speculative. Whatever I'm talking is in speculation. Whatever I'll talk on the slide is probably real time. And that is where Akola, Yavatmal, and those districts from Vidarbha, they had very low prevalence of COVID. They were not hit in the first wave. So I got calls from doctors there. They said, Doc, one person in our family had COVID. Now 8 members got COVID. After 3 days, he calls me up and says, Sir, our whole colony is positive. Whole had 50% test positive. So we realized we are not dealing with something. We are dealing with something different. Government of India was also saying that तुम लोग क्या कर रहे हो? What the central team used to come. Used to be like examination. Used to come and their whole idea was to see. They came with the intent to help. But when they come with the intent to help, it's not easy because we don't know what we're dealing with. We knew for sure that we are dealing with something. Probably that was the first doctor. So the strain which Dr. Rajesh Karakarti, the microbiologist from Pune, picked up, came out to be Kappa. That was sent to NIV. And she took almost a month to give the result. Just like then, it took almost a month to give the result. It takes time. See, when you're told to give a result overnight in a science lab, it takes time. And right now, Lab Shashank doesn't have any sample of that patient. Very little sample. So I don't know how it will pan out. So it's not easy. It took a month. See the spread. We had to take proactive actions. Any country will have elections, any country will have mobility. Economics takes the priority. So people have to live their livelihoods. They are more important than lives. Those type of debates are started. Nobody wanted to now have another talk. Nobody really wanted to have that talk. So again, we didn't know what we were doing. But we knew for sure there's something about it. Once on the public debate, I spoke to the Director of CSIR, Dr. Shekhar Mandle. He said, we will analyze the strain again. Very good system testing that one get I said. We speak to our clinician. He's a pulmonologist from AIMS. Very well trained. I didn't know him at all. I spoke to him. He said, send us the sample. We'll see what test we can do. We'll give you a turnaround time of 48 to 70. And their scientists, Secretary, I can Google them and Subha. Both of them said, sir, we will try our best to see whether there's a real variant. Because clinically you are saying this is a variant. I said, sir, it's possible. I know the transmission rate. If in Mumbai city there's a flat or a chawl, and if there are 10 people having COVID, the whole building doesn't get COVID. In a family of 8, if one gets COVID, maximum 2 or 3 will get. Nobody else will test positive. Here everybody is testing positive. We knew that this is more transmissible variant, clearly. So I said, ye to kuch alag hai. I didn't know what it was. My answer is scientists have to give us answers. This is different. Okay. Both the ICMR and the CSIR and the INSACOG, and Dr. Jamil was at that INSACOG team. They all gave me the same conclusion that probably this is anyway, and this is Delta. This is not Alpha. Delhi had Alpha and Delta. So the need for Delhi for oxygen was much more than Mumbai. And they had a bad disease. Second wave left us with a lot of scars. Second wave left, but we must compliment our governments, both state and central. They spoke to all of us. I had a direct access speaking to a chief minister of a state. In my life, I don't have any political connection. I am an ordinary middle class person. Actually, my father founded an institute right behind. It's called Maharashtra Institute of Liver Studies. You know more now, like a prostate cancer, a couple of years back. He founded an institute. So I came from a very middle class background, and I didn't have any of these. I could talk to a chief minister. I could talk to a prime minister. He was listening to what we were doing. They were listening to us. They had our ears. I was saying here, remdesivir scare is again high. Everybody wanted remdesivir. Remdesivir data was very clear cut. It does not have anything to do with mortality. It improves clinical recovery. It reduces hospital time. So clinicians wanted it because they wanted to shorten the length of stay in the hospital, because then they can accommodate another patient. But there is a scarcity, we have to see what to do. But it's not saving lives. Steroid saves lives, prone position saves lives, oxygen saves lives. But we could talk this, and leaders took decisions based on scientific input given to them. So second wave was a challenge. What we observed in the first wave in Mumbai is that if you keep all the controls at one place, it's very difficult to control them. With the second wave, I think I must congratulate both our chief minister and our minister. They took a decision and we decided to declare about it. Mumbai has 24 wards. Each ward officer became a commissioner and it was empowered. And that was only the reason Mumbai did not have mortality and the devastation Delhi had in the second wave. That was the Mumbai model. It is now replicated all over the world. They realize that you have to declutter. So don't declutter and don't empower small units. For example, I'm sure Dr. Satyava heads this institute, but she has all her empowered units here within herself. And she is herself coming from a small unit going into a big unit. So if you don't empower, you will not get results. So every ward officer was as good as the commissioner of that place. And they were all given targets. What's their test positivity rate? What is their doubling time? What is their mortality? What is happening? Different. Should we seal the building or not? And the micro containment policies. And based on that, the response of second wave probably was much better than the third. But still, these lands, jumbos were not disbanded. We were able to recover them. But by that time, we had more therapeutics. And we got advent of monoclonal antibodies after that. So we still had a lot of Delta and Kappa in the second wave, which persisted in Mumbai because Mumbai got a thick tail. You know what used to happen is, we are, if you call all of us as Ram Janata, okay, the rich people stayed in their ghettos inside the house. They never got out. And then after the pandemic, the wave started coming down, they started gradually getting out and getting the disease. So Mumbai continuously had a thick tail. In Delhi, it was not like that. Delhi, the peak used to go up and suddenly come down. But Mumbai had a thick tail in the first wave and in the second. We were getting cases of Delta right up to October, November. And by October, November, we thought that the wave is over, everything is done. And you know what happened in, in South Africa. The third wave was very peculiar. Third wave, fundamentally, we know that there was this Hong Kong businessman, who was a diamond merchant, and you know that uncut diamonds are there in South Africa. We traveled from Hong Kong to South Africa on 10th of November, just like the South African case which came. When he traveled there, probably picked up a Omicron there, and went back to Hong Kong. Hong Kong had a draconian policy. Any person who enters Hong Kong, because they had the SARS-1 pandemic, you had quarantine for 21 days. Mandatory 14-day quarantine in a hotel and 7-day quarantine at home. Mandatory. And this gentleman only once to have green tea opened his hotel room, and there was a patient in front, I mean not a patient, but there was a person in front of him who he looked at, and that person also was tested for. They tested negative when they came in, just like this South African lady. They were fully vaccinated again with Pfizer. That is mRNA platform, which is now, we don't know whether how much robust that platform is, because that was all built on spike protein. So when you do too much of building on a particular platform, the virus is always going to get smarter of us. So obviously there were mutations, 50 mutations spiked on them. So obviously there was immunity. It's so evident. I mean, any immunologist, and all of you all know immunology and science better than me. But this was evident that this is what happened. But the virulence was low. So that Hong Kong patient, they clearly put it on the display that this is Omicron. By that time, you know, Dr. Julio Oliveira's lab clearly told us that, you know, there is this Omicron variant. It's actually a mid state. And clearly it is. And that was going to create a havoc. Simultaneously, there was Dr. Andrea, who is, and I'm on the Commonwealth Foundation, I had a opportunity to talk to her much before, you know, she became famous for the South African. Because we always used to meet as Commonwealth Medical Association. He said, I'm a clinician, I'm from this region. Patients are very mild, it's like cough and cold. Nobody died, nothing to us. So, you know, nobody believed that we said. So I ensured that she talks to our core team in Government of India, Government of Maharashtra. She talked to all of us. She said, there's nothing to it. This is just a mind disease. Yes, you can have mortality. South Africa did have mortality. But it's only those vulnerable groups. Somebody has a kidney transplant, somebody has second disease, third disease. In them, it would hasten them, just like any food. So that gave us that confidence that we have Omicron. And Omicron initially was BA1, then was BA2 and BA3. India predominantly in north and east had BA2. And genomic sequencing again with us. And that BA2 is still there, and it wiped out Delta. It clearly wiped out Delta. Now recombinant has arrived at 600 cases in UK. in public domain in end of March, and they still don't know where it is going. But we have better tools. For the third wave, we had much better tools. But we realized clinically, COVID is nose COVID, throat COVID, and lung COVID. Lung COVID was bad. Nose and throat COVID is managed. And when vulnerable groups, you can get a foot. And the BA2 can behave like a delta if you are immunocompromised or if you deteriorate. I'm going to show you a glimpse of slides on some evidence based on treatment options of COVID. COVID is now probably just like HIV, a manageable disease. We have to live with COVID. We have rapid antigen tests now, self-testing, isolation, and teaching. Fundamentally, it is the Indian vaccine story. As I talk today, 185 crore Indian vaccine. Okay, vaccine, we have only two platforms. Currently, largely used. One is the adenovirus platform, which is Covishield, which most of us have taken, or the GILT platform, which is the vaccine, which again ICMR has a huge role in contributing. We actually have a better version of mRNA platform. It's a DNA version, which DBD put some money with IDS came out with. We also have a subunit vaccine platform. We have an indigenously made mRNA platform undergoing research. You know why vaccine research in India still didn't progress very well? Because after May of 2021, there were no research volunteers because of the large exposure we received. It was very difficult. The mRNA project, which is in Pune, couldn't get volunteers. They had to get patients from now who are antibody. They found it impossible. So people are criticizing we are not generating evidence. But we didn't have volunteers. In US, Europe, there are anti-vaxxers who are sitting at home, so they can just go and volunteer for clinical trials. But in India, it was not easy to get volunteers for clinical trials. It was tough. Still, we have innovated, we have done incremental innovation. Our scientists are still struggling. I must also congratulate pharmaceutical industry and diagnostics. They rose to the plate. They did whatever they could. And we have some platforms now. So I think we have a hybrid immunity today. We have got a large exposure to Covishield or Covax, predominantly Covax. And now they are developing the nasal platform. I'm very excited about. I think that's the sterilizing. Remember, vaccines only save lives in most of the people. See, public health is very different from individual. This is the reason, as a task force I enjoyed is one was health communication. And second is public health decisions sometimes don't agree with science. In public health, when a decision is taken, and all of you are scientists, it is not individualistic, it is not political. It is what is best practice for most of the people, most of the time. That's the overarching principle. So if it is going to benefit most of the people, most of the time, we have to take a risk. So if opening of a restaurant till 12 o'clock is going to be beneficial for economy, yes. But will it be a transmission risk? For most of the people, the answer is no. Then the decision was taken. That is where the governments or administration, and that's what we learned from the IS office. Our Indian Administrative Service, they took those decisions based on these overarching. So they use science, they use their laws of the land, they use the Disaster Management Act, and they took those decisions for benefiting people at large and looking at our healthcare public health infrastructure back. For example, if we had not locked down in the first wave, look at the number of lives we would have lost. The vulnerable population which would have been susceptible. So many of us, in hindsight, we think, a lot of people, they just did it, they would have died anyway. People are ready to criticize, but you need to understand a lot of thinking went on it, and a lot of thinking was science. So this was the overall story. Yes, still COVID is not over. My take on it is that we are good to go for 3 to 6 months. I think for next 3 to 6 months, there is a large exposure naturally, large vaccine exposure. We still will need to do a little bit of indoor masking, some degree of COVID appropriate behavior. But next 3 months, we are good. We'll probably get a fourth wave. It may be very mild, with a milder strain, unless a new variant of concern again. We never know. I think we still need to be vigilant. To say that COVID is over is not right. If WHO declares the end of the pandemic, then only from public health standpoint we can use the word endemic. To ask me, if you discount the word and just look at India, it's already endemic. Mumbai city is clearly endemic. It's going to happen. But look at the third wave. We didn't have a day. Biggest thing is the exposure is so high, 100% vaccination. Okay, that's technically 100% because people come from Gaon, take it here and go back. It still gets counted in India. You know, Gurgaon is 117% vaccination because there's a lot of migrant population. See, mobility and migration are the biggest challenges for big cities. So we are population dense hubs, and we also are a global hub. A lot of business is transacted in Mumbai. That's why a lot of business people come. That's where we will be reporting. So we have to continue sentinel surveillance as well as genomic surveillance. So I'm going to give you in the next maybe 10-15 minutes a little glimpse on COVID treatment regimens of the world and where will they evolve. Let me see if I can check the slides. So, are these slides visible? So these slides I'm just showing you, just tell you COVID science, how science has evolved. When Omicron came, there were two camps: inevitability camp and avoidance camp. I find this very strange when I'm talking about this. Okay, so the inevitability camp said it's a mild disease. Avoidance camp said it's less severe. Mild isn't always mild. See, this is a global debate on Twitter. How many of you are on Twitter? All scientists should be on Twitter. You know why? Because for me it is very easy. You all have at least access to institute, so you get full text articles. I don't subscribe to all the articles. I don't have access to full text. Okay, so for me, Twitter is the way to get full text articles and to know what is latest published. Because every author who matters in planet Earth, okay, puts out things on a Twitter of the top caliber. Which has an edge index more than say 40, 50 and all. My edge index is 42 or something. It's very low compared to other people. Because my friends like Mohan and all are above 100. So they could do that science because they had a science foundation backing them up. We are still struggling as clinicians. Because as clinicians we can't do that. Our science left when we finished our DM in endocrinology. We couldn't continue that science. So that my narrative was inevitability, avoidance said it's less severe. Then we had animal data from Omicron. So, lung to lung cell virulence in 5 studies. It said it's mild. They said hamsters, mice, and culture diseases are not people. Okay. So I'm sure this is a science audience, so you will understand this slide. Then people said vaccines, infections, induced T cell, hold up well. So inevitably will protect versus severe disease. Many people like aged, immunocompromised won't have an assured layer of it. Absolutely. So one is a skeptic. So one is positive, one is negative. Okay. Third shot protects 75% on symptomatic infection. Second shot protects 70% on this thing. This is vaccine material. It's a very short duration of 3 months. That's all I'm saying. The only thing I can guarantee you today is 3 months unlikely. That's good, but plenty of breakthrough effects. Long COVID unknown, people say nothing to worry. Even today, I have patients of Omicron who call me with severe fatigue, severe tiredness, and they just are not known. It's a big problem for science. If you all want a thesis to pick up, neuroendocrinology madam was there, I spoke to her. If there's one area in COVID which you can research in neuroendocrinology, it's long COVID. It's very much there. It's very much here and there. Okay. But there are people who say, no, nothing will happen. People who put them to psychiatrists. That's sad. Then there's a pill. Pfizer had this big pill. Pfizer made maximum money from it. Should not sound anti-pharma, but they made a vaccine which didn't work. Okay, but made $40 billion from it. And now they have made a pill which is not in India still, but they have now given the license to Indian generic manufacturers. Our manufacturers are the best sugar. They can make any pill. Once we get a formula, we can reverse it. And we can make it at quality of 5. So, innovative income, we don't need it. It's a small supply and high transmissibility. So when we are hybrid technology, there's nothing to worry about the stem cell. It's a way to reduce transmission. So these were the two camps. We battled in two camps. So when I was telling you the story of third wave, I'm telling you what's happening. This was the definition of the spike protein. Specimens were collected only November 11 to 23rd. So if anybody calls himself or herself Omicron expert, nobody in the world is Omicron expert because the data is very fresh and new. We don't know the science, and a lot of science in public domain may not be really the science which is really there. The H gene target failure was a big challenge. And in BA2, H gene is present. So this was a mistake people made. This was only true for BA1, and this was that Gauteng province, which was there in South Africa. So beta had a clear lineage, gamma had a clear lineage, delta had a clear lineage. In Omicron, which came probably from Botswana, there was an HIV immunocompromised individual from where it came. Okay, there was spike protein mutations of interest. Impact on transmissibility, now we have reasonable data. I am still putting it as blank because the scientist in me tells me that probably it is more transmissible over contagious. Impact on immunity, probably, yes, it may have immune escape. And impact on severity, less frequent. That probably I can put that slide and put a box there, but I'll still put it back. Because to say anything in less than 1 year is unfair. Other variants, we have better data, at least more than a year data, good evidence based in science, nature, cell type of journals to say that. But this is still a blank. Okay, and now it has replaced delta, gamma, beta, alpha. So clearly, the only thing we know on Omicron, rapidly transmissible, super mutant is R0 is unknown, replace delta, more transmissible, immune escape possible. Severity virulence, less, clearly less. Now we replace the how South Africa. Picked up this slide, Omicron wave clearly replaced the Delta wave. All waves replaced very fast. Look at the difference. All of you know these graphs. Look at Delta, look at Omicron, look at the mutation. I mean, unbelievable number. Every part of the virus is mutated. This was, as I said, we have to identify risk scores. We identified this risk score, which I put out as an edit in one of our medical studies because we wanted to put out there. But we had hotspots and red zones in India, whether it's Mumbai, Pune, Ahmedabad, Delhi, Indore, anywhere. I have actually said at that time that ICMR and our revealing the sequence of genome and strains of viruses and mutants from India. But we have to save lives. So what is the vulnerability and mortality risk? Age, male gender, hypertension, diabetes, obesity, chronic heart disease, slow feeding asthma, chronic lung disease, chronic kidney, liver disease, immunodeficient states, corticosteroid transplant recipients, and pregnancy and children below 10 years need attention because we didn't know and we still don't. We have a child health focus now, but children have thymus protected. We must have heard my friend Chandrakant Daharia saying कि बच्चों के स्कूल में मास्क की भी जरूरत नहीं है. That's created a problem. Because they have inbuilt immunity, and we are a BCG vaccinated country. So very clearly we have that. So who can get hospitalized? Only these groups: asthma, hypertension, obesity, CKD, obesity, more conditions. Very clear data which was there. And the viral competitive advantage of Omicron was very high. So clearly we knew that the Omicron as a variant had highest transmissibility, lower disease severity. So I'm filling up the gap now, and had a very high escape, both from vaccine and natural infection. So a lot of people who got Delta or got double vaccinated still got Omicron. So the science is emerging science. As I said, Omicron science is not absolute. We still don't know 100% on Omicron. On alpha, beta, and delta, I think with good confidence we can know what's happening. So COVID has 3 subtypes. Unvaccinated with no past COVID, very difficult to get, but you can get it in India. You go to Jawar Mokhada, which is I have a rural outreach from I was saying. Satya was telling me there is a rural outreach for that. You go there, you still get patients who are completely unexposed, and you might pick them up for a trial. You have that rural outreach center. We get their patients because they have zero exposure. They don't come to cities, they don't move. And COVID has just not. That's still possible. Then we have breakthroughs, either to partial or total booster dose, and then we have all the 3 combination most people have got. Now that's the COVID issue. This was the old timetable. 80% no symptoms, 14% severe symptoms, 5% needed ICU care. How narrative changed in Omicron? 80 became 95%. That's why we didn't have any major challenge between mid-December to mid-January. There was a lockdown, but that lockdown was as good as no lockdown. Most of y'all were still coming. We are all sitting here. The severe disease 14 became 4%, ICU became 1%. So that was the big difference. And that's why we are confident. We are sitting here today and talking to us. And it's all about our immune response. This slide, Madam Madan should talk because she's an immunologist. But it's all about our adaptive immune response, our interferon, the TH1 activation, and neutralizing it. And people who can't mount that adequate immune response, they will delete it. They'll have endocrine cell death, cytokine storm, and so on and so forth. So clearly we knew the stages of the disease. Early infection, typical flu-like syndrome, most of the time asymptomatic, very high value, transmissible. With those first 3 days when you are asymptomatic, when you are most transmissible. Then we had a lung response, and then we had this hyperinflammatory response. But in evidence-based medicine, we need this rating of recommendation and rating of evidence. And clinically, we have to look at that. So the only thing which matters in India is we have so many biomarkers. Only thing which worked with evidence-based was CBC CRP. Complete blood count is 10 rupees or free. In that, if your red cell build is more than 14.5, you're likely to be killed. You don't need to do that expensive D-dimer or that LDH or interleukin 6. You don't need it because see, India is a poor country. We have limited resources. CBC red cell with more than 14.5, very good JAMA paper, outcome data paper, because we are now looking at clinical outcomes. We know this patient like neutrophil lymphocyte ratio was an old ratio, Chinese used it a lot, and CRP. Between these two, in 50-100 rupees, you are getting everything, all the information you need. Of course, if you can afford, you can do an IL-6, you can do D-dimer, you can do ferritin, you can do LDH. If you are in a research setup, in a big hospital setup, it's okay. But otherwise, CBC CRP is good enough to tell you prediction value of CRP became very, very popular. Only 7 things for doctors we taught in COVID. Monitor temperature if it is above 100, give paracetamol. If the pulse is high, go to hospital. If respiratory rate is high, go to hospital. If blood pressure, sugar is high, contact your doctor telephonically. And if your saturation level after 6-minute walk test drops by 3% or 93% and below, you need to clearly identify that this patient needs to focus. This is the COVID thermometer. Pulse oximeter, most people were masking and taking their thing. As soon as they remove the mask, the saturation is shrinking. The cold extremities have to be warm, particularly in Delhi and North India. You know how cold it gets. Wait for the reading for 30 to 60. And it's only the middle of the reading. There were simple tips on pulse oximeter. That was our main thing. The old COVID timetable was 14 to 21 days. It became 7 to 14. Post COVID is 3 months. However, all people who suffer from COVID for 3 months, they should see their doctor. Particularly. It was right approach, right time, right medicine. There was no need to use antibiotics, antibiotics. Always speak to the patient, of course. Don't talk to a relative. And we never, the life-saving drugs were simple things like aspirin, baby aspirin, statin, anticoagulants, and aspirin. Budesonide was good. There were trials to show that. But identify people at risk. It's all about risk factor identity. Who are the most vulnerable to die? These are the ones who will die. Solid organ transplant, blood cancer and active chemo patients, dialysis patients, people on immunotherapies, primary. This group is very, very much. This group, even now, if you ask me, if I had any of these conditions, I would definitely cover them. Even now, if I'm sitting with all of them. They are vulnerable individuals. While this group is important, we should take care. For the next 3 to 6 months, this group should take care for at least a year. So things changed in COVID times. We have better treatments, we have an antibody therapy, and we know what to handle well. So Government of India, these are Ministry of Health guidelines. They said home isolation, isolate yourself at home, use teleconsultation platform, caregiver platform. But the main thing is this 7 points or 6 points. Who to it? The difficulty in breathing, temperature not coming down for 3 days, saturation drops, persistent pain on pressure on chest, mental confusion, severe fatigue and myalgia. Simple guidelines. I'm straight talking from MOH guidelines, directly from MOH guidelines. So that's all the my cases, and I'm not getting into details of that. What about this monoclonal antibody cocktail? So, because what they did, plasma failed, unfortunately. Because plasma was a very old theory, and it was not specific, and we didn't get high titer plasmas. But from the plasma, a lot of monoclonal antibodies were generated. That's what all scientists like all do. They had target specific viral epitopes, mass producible in a quantity, and they clearly knew what to do. So the antibody which became very popular for delta and same lives for this antibody, Casirivimab, and that therapy had a role, outcome based. So the NIH panel, which is evidence based panel, said that this antibody, if you give it early, the first 3 days saves lives. Chloroquine, azithromycin did really well. Dexamethasone early doesn't work, only works inside the hospital. Doxycycline didn't work. Everything else is investigation, including AMR. Only identify the people who are at risk to deteriorate or die. That's all it says. So this lytic antibody is now available in India, but in Omicron it doesn't work. We can use for post-exposure prophylaxis. This is that Hegeron antibody which is available. It's expensive. It's 50,000 rupees, and it comes in a vial. And they had very good data, excellent data. I don't want to go into details, but good science for them. All New England Journal publications, publications, and they clearly showed that it can work very well. And this is against all variants, but in vitro data showed that it doesn't work against them. So currently we have all these two other antibodies. There is an antibody called Dushi, which can work against Omicron, not available in India. Sotorolabam is available from GSK, not available in India, can work against Omicron. And then there are newer antibodies, like Biocon, they are producing this antibody that can work. But now people have given up this system because these antibodies can really save lives in those. We have seen that. So data was very good. But as I said, in that Omicron, they don't work. Anecdotal evidence and cost is a little. What about antivirals? When we need good antivirals. And at every university, they develop Molnupiravir. So our DGICMR was not very fond of the drug. Okay, it was a old agent. It was a chain terminator. It's a broad spectrum drug developed at Emory, and Emory only donated. Coca-Cola funded Emory University, Atlanta, Georgia. Part of Emory University went on to become CDC sector for disease control. You don't know the history, I can tell you a lot of history and trivia. It was a nucleoside enzyme. It basically made errors in viral RNA. So fundamentally, there are two steps on Molnupiravir. Very good drug. It was symptomatic. We used it in no matter. And particularly in senior citizens vulnerable at home. Fundamentally, it incorporated the MTP and created copy errors. So fundamentally, Molnupiravir worked by replicating, by introducing copying errors during viral RNA replication. That's how it worked and deactivated. If you use early, 4 tablets twice a day for 5 days, it works very, very well. So there was no question asked. But don't use it in children, don't use it in people below 15, don't use it in pregnant women, don't use it in men below 50. And very good data. Okay, excellent data. In fact, in trials were prematurely terminated by US FDA. Because in 3 days, the virus was cleared. In public health, we want somebody to be negative as early as possible. And the biggest challenge with RT-PCR test was it doesn't recognize dead virus and live virus. So many people kept on shedding the dead virus and kept on testing positive. So this was the data where US FDA decided to give it faster. That by day 3, the infectivity was reached. So from a public health standpoint, that is why that 5-day mask mandate came. So Delta Airlines CEO told President Biden, look, we cannot have our population affected. And Molnupiravir had this trial in the New Journal of Medicine, and it clearly showed the more trial, the phase 3 trial, and there was 30% reduction in hospitalization and death. And that was clear cut. But in that subgroup analysis, WHO also, and hardly any sign. We use this drug in symptomatic people with vulnerable groups about it. Okay, excellent pharmacokinetics, safety, tolerability, no drug-to-drug interactions. But don't use it in pregnant, lactating, pediatrics. But can be used in kidney patient, liver patient, and derivative. So that is very good. And it is available, yeah, and generally companies. The second drug which will now be available in India, and India is still not, the decision is about to approve it with the subject expert group is Nirmatrelvin ritonavir. That is the Pfizer combination. So monoclonal antibodies reduction of hospitalization is from 10 to 3%, and hospitalization reduction is 70 to 80. Molnupiravir is 10 to 7%, hospitalization reduction is 30%. But it got flipped by the Pfizer molecule because it reduced hospitalization from 7 to 1%, and efficacy on hospitalization was 80%. So these are the three COVID therapeutics who are now available to save lives in the world. And then came remdesivir rediscovery. Remdesivir was almost given up by second wave, except clinical recovery. But in office care, they gave injectable remdesivir in Omicron for 3 doses, one daily for 3 doses, and it clearly showed very good recovery. This was the data published. Early remdesivir, okay, allows patients not to progress. And you know, LGM has an impact factor of more than 86 now. It's a very high impact factor, and they were able to show that remdesivir still is not out. That's what was the remdesivir data. So what were doctors left with, and what are we left with today if we get COVID? We have inhaled steroid, we have molnupiravir, we have that antibody from Roche, we have that antibody now available from either Astra or from GSK, not yet available in India. We have remdesivir, and of course we have steroid with tocilizumab, itolizumab, and remdesivir and paracetamol. So that is still there. So India had its own little things, and because you are an immunologist, I am telling you a little bit about this. That IL-6 is blocked by tocilizumab, but a Cuban-Indian collaboration, Bangalore, made this itolizumab, which is nothing but anti-CD6. It binds to CD6 receptor, blocks the alkyl-mediated T-cell activation. It's a pan modulator. It was originally for plaque cirrhosis. It's a repurposed drug. It can be used for lupus nephritis. It can be used for refractory asthma. And tocilizumab is also for highly specific, so it's upstream pathway and downstream pathway are shorter. And IL-1 antagonist is not available. So one is a cytokine receptor blocker, one is cytokine formation blocker. And these drugs were again out of market in the second. They saved a lot of money. But of course, this indication is very restricted. Somebody is desaturated despite of steroids. It's a conditional recommendation because the certainty of evidence is very low. So these drugs came in, and molnupiravir. So currently our algorithm was very simple. Asymptomatic, comorbidity or no comorbidity observed, no blood test. Okay, this was our government of Maharashtra. Symptomatic without fever, but rhinitis, cough, comorbidities, observe no blood test, if persistent, some budesonide or inhaler twice a day, and if there are no comorbidities, may or may not treat. Symptomatic with fever and no comorbidities, age more than 60 years, we give money. If fever persisted, we moved them to hospital or give them injectable dose. There are no comorbidities below 60 years, paracetamol and symptomatic. So this is how the narrative was. And ICMR, of course, did not get into this one. They just said symptomatic. But for the whole country, then once you put it out as an official mandate, you have to make the drug available to every citizen. That's not possible. So that's very, very tough. Then of course we had our own. So where is the status of the antibodies? Delta variant is Cipla, Casirivimab, Itolizumab work. Omicron variant, molnupiravir, remdesivir work. Hospitalized patients, remdesivir. That's the status today. That's where we are today. And we have to find out who is at risk. So everybody wanted to know who is at risk. So they wanted to do a simple score. Again. So if you are Indian, your score goes up to anyway. Okay. Then if your age is high, your score goes up. If you have comorbidities like diabetes, immunocompromises, obesity, heart disease, chronic artery disease, any of those things, the score goes up. In short of that, the score goes up. The score is more than 8, we should aggressively. And again, these are the highest population, these are the comorbidities, and we should be hospitalized. Our final goal is very simple: 0 COVID deaths, no severe disease, mild, manageable, endemic disease. And probably Omicron has been the change. Probably it has been the change. So on 7th April, we still need to be responsible. COVID still is predictably unpredictable, but we need to save lives. And I think that's where I'll stop. I'll be more than happy to answer questions. Thank you for a question. Sorry, I overshot my time by a couple of minutes. Shall we only 1 hour?
Yeah. Sir, with respect to diabetes, this is a wide variation. How long it will take, sir? If a non-diabetic patient or a pre-diabetic patient, high blood sugars. So post-COVID, how long it will take, sir? Because there is wide variation.
So I'll answer your question. See, COVID itself as a virus is known to cause diabetes. So there are 4 problems. If you are a diabetic, well controlled, got COVID, COVID made it worse, particularly the Delta and the ancestors. You got in the hospital, got steroids, it became further worse. And that person likelihood of death went down. If you did not have COVID, but you had pre-diabetes and got COVID, then that pre-diabetes got converted to diabetes. That was the second scenario. The third scenario is you didn't have any pre-diabetes, you didn't have any diabetes, but you had family history of diabetes. You got COVID, you got steroids, you got to the hospital, again you had hyperglycemia for some time. That's where the Mucor pandemic came out. The second wave, we had the Mucor. I deliberately avoided it. And there's a narrative behind it. So I tell your director, madam, you can ask the company. Or talk of it. It's done and dusted. But diabetes had a role in that Mucor, uncontrolled diabetes. Finally, now, there's very, very elegant data. The Indian scientist called Professor Kamlesh Murthy from Leicester was published this data. British scientists did a lot of scientific data generation in the clinical study. They published better evidence than most people around. I'm not saying it because she played in UK, but they did do some good science there. They did publish well in the science front. China and UK published the most. They have shown that there is a distinct entity called COVID. So people who have had COVID, after 2 years also, I can correlate that they got diabetes. And there's probably a link between that, and there's very good scientific evidence for that. But there are no H2 receptors in the pancreas beta cells. But there is some upregulation of second and third generation cells and some peptides which damage the beta cells. Very clear data. So there is a COVID-induced pancreatopathy which leads to development of diabetes. And many of these patients need insulin for life. They're stuck with insulin. What you're saying is very true, that COVID has 4 subtypes of diabetes. One is diabetics getting worse, pre-diabetics getting converted to diabetes, COVID-related diabetes, and stress diabetes which comes because of hospitalization and steroids due to that. Those are the 4 variants. And all the 4 variants now are distinct entity. We can say after probably the 4th variant has only now got better database.
Thank you for that wonderful talk, and you took us through the journey. It was a flashback, I think, for all of us. There is a lot of hesitancy for booster dose, especially even among the vulnerable. So what is task force recommendation? Or we wait because currently there is not much of COVID, and that is the way people are seeing it in public domain. Not many are wanting to go ahead for the booster dose.
This is a question asked right from Parliament to the Supreme Court to the High Court. So I will have to be very correct in my answer. And I'll have to be politically also very correct. You are IC1 issue, you are IC1.
Another question also.
Let me finish this because this is a difficult one.
Okay.
Currently, the entire team, and Professor Arora was a very close friend. He and me had to once defend this on Arnab Goswami, how difficult it is. So he and me were for delaying and deferring booster dose, and the rest of the panel was attached. including us, you know how it is. Not easy to handle. He's my good friend, but it's not easy to handle, okay? So the response we both gave, I'm telling you the same response. We have not generated high quality science in additional dose space. And the NTIE has given 3 data. Just before the Omicron wave in December. Healthcare workers as well as frontline workers who got their vaccination 9 months back, where the antibodies had come down, can and should take vaccine. Vaccine is voluntary. Second is people above 60 who have underlying medical conditions. It is left open for their doctors to decide. Third is the gap had to be 9 months. The presumption and the science behind that is highly. A large Indian population in healthcare workers, in the frontline workers, and in the vulnerable groups were already exposed. So they had some degree of vaccine protection. They already had a Covishield or a Covaxin in their system. And therefore, and there is no mix and match data from India, except that anecdotal ICMR paper from Gorakhpur, which is actually an anecdote. You know, it's like a specialty. We don't have that. CMC Velo data has never come from the Gandhi branch. It's not popular. We don't have that data. In absence of that data, and we have also seen the Israel experiment, they give two boosters, 2 regular doses, 2 boosters, and still COVID is at the peak. Only thing it has made a difference is on mortality rates. So therefore, I think they are waiting for appropriate science to be generated, for extra doses to be made available for people at large. Again, this is a public health decision making based on science and evidence. Because, and in Mumbai, we are awaiting the next dose survey. 100% of Mumbai vaccinated. Most people got their first and second dose, and second dose, many people are still due. There was a long gap between first and second. Then many people got Omicron now. Again, they have to wait for 3 months. So there has been a lot of mix and match. And it is still centrally funded. It's not, you just can't go and shop a vaccine. Why? Again, the credit goes to scientists and Indian government. They feel if you shop and just use booster, it gives you a false sense of security. It's like driving a bike at 150 kilometers an hour with a helmet, recklessly. So it's not guided by good science. So I think the science is critical. And most of these vaccines don't have that robust data. Most of them are having given a skill. You see the various new strains which are coming there. We definitely need. So my bet is on the nasal vaccine, which clinical phase 3 trials are now underway from Covaxin, which is actually not the field vaccine. The nasal vaccine of Bharat Biotech and ICMR is actually Covishield, the adenoviral platform in the nose. And then I want to see that data. But just like you are a scientist, I'm also scientifically inclined clinician. I'm like a daily wage earner who's a doctor. Okay. I want to see that data to be more convinced. But these groups should take. You all are into lab sciences. So you do have exposure. You feel you should take, you are in that program. But general recommendation is not. And then was 15 to 18 children, then 14 to 12. It has been also very clear. It's most of the people, most of the time. With 185 crore and large exposure, I think that is a sign. I think booster science for India, we need more data. I think lack of data is the rate limiting step, not allowing a general data. Also, there is still a population. See, COVID cannot be eliminated from planet Earth. Till the full 7 billion people on planet Earth at least get first of all for exposure. So that has not happened. We still have people within India. If you go to small places in Maharashtra, also there will be people who are not vaccinated. All would be the same. Also, some ghettos in Mumbai. So that's it. So I can't answer more than that. Offline, I can talk.
You had another.
Yeah, another question was something that I could not analyze the rationale behind night curfews because there was a lot of debate.
Okay, so I'll answer that.
Yeah.
That question I can answer. Okay, that's a simple question.
Yeah.
Okay, see the rationale behind night curfew was that some people in India are sometimes, what was my last statement? Be responsible. We are not self-regulated. And people want to go out, right? Curfew was with a administrative logic, not a scientific logic. Based on a philosophy that if you implement night curfews, people get a fear, population at large gets a fear instilled in them that there is something coming up. That's all. Nothing good. It is more of administrative logic for the administration. What it's okay. See, there is a big fight between individual rights and the spread of this. Really, it doesn't make, for me, it doesn't make any logic. COVID virus doesn't travel at night. Okay. But at the same time, if you don't instill some degree of fear, people behave recklessly, tend to mix, tend to get irresponsible. So there has to be some sense pushed there. So these are administrative yardsticks used by our administrators. They are administration, they rule the country. So they thought that this is a policing act. Okay, so that it's more coming from an administrative side, the disaster management. Now government of India is very clear, they have moved everything. So now none of this will, even if they want, they can't do that. Unless we get. So I think the logic was more administrative and less scientific. Okay, but the rationale was to change behavior. I would say, if I will give a scientific explanation, it was like a behavioral threat type. So I have learned a lot of behavioral science in these last 2 years. I should do a Facebook live show every Sunday. I should do it on Manish Shetty, psychiatrist. And we realized that threats don't work. It has to be voluntary parts. But India में ना डंडा नहीं लगाएगा तो कोई नहीं करता. जैसे मास्क निकाल दिया, half the people are out. Patients in the clinic, yesterday I was in patient, they have to remove the mask. So थोड़ा सा, that is the thinking behind it. So I'm just telling you, presumptive thinking. I cannot say this. Presumptive thinking. I hope that answers the question. Yes, ma'am. Not really, but we didn't know. So initially we thought ACE inhibitors are harmful. See, COVID had these U-turns. So in the beginning, people thought NSAIDs are harmful and deleterious. But ultimately, those anti-inflammatories only work. So ultimately, steroid is also an anti-inflammatory. But you see, the point was, this was a Chinese narrative which was created that lupus could harm and steroids may work. Okay. But there's no clinical evidence. Like indomethacin, the Indian scientist in the US who called me up giving that way. That's the first time I contacted Dr. Madar. So we were talking about some degree. She has done work in surfactant and we thought it could work on the cytokine storm. And so they felt that anti-inflammatories can work. But as I said, we don't know. What can work. It's any anti-inflammatory, anti-cytokine can work. But when you have to put it in the COVID space, you have to do an RCT. Most RCTs were adaptive trials. They were not the robust RCTs. So the data and the level of evidence was poor. So initially that skepticism was there, but later on. But COVID is all about mutants. See, off-patent drug like hydroxychloroquine or off-patent drug like ivermectin never got into share. Because including Western journals, they shut it down. And though ICMR struggled and tried its best to put out some good science, and we supported ICMR. So the rationale was correct. Okay, because they observed in the one city that people who had lupus and who took hydroxychloroquine never had severity. So that was the logic of hydroxychloroquine in China. And the idea was picked up by our scientists in India. And we tried to use it in the prophylactic because we had malaria experience. And it might have worked in us, but we all took it as healthcare workers. We were at front line. Okay, I took it in May of 2020 at presumptive COVID, at everything. I didn't have remdesivir, I didn't have favipiravir. What did I take? I took azithromycin, though I said it is not evidence. I took it myself. So I'm not ashamed to say it. There was nothing available. 13th May 2020, there was nothing available. Okay, I took ivermectin, azithromycin and hydroxychloroquine, and after one day I was puking at home, and I was isolated. And I live with my 82-year-old mother. It's very difficult. It's impossible. We don't know. So at that is the time I got to fulfill was. Later on it went out because steroid is off-patent, cheap, effective, useful. So therefore it really went out. So the whole NSAID story got out of it. But many of those NSAIDs, some people did work. So if you see the literature which is published, And most of the other thing which I forgot to tell because you are scientists. 72% of literature, I heard a talk in the US virtually. 72% of literature published in COVID space was on, what is that called? No. Preprint.
Preprint.
Non-peer reviewed preprint.
Right.
72% of it has not got peer reviewed and got published. It's a statement. I mean, I have not made a slide. I told my, we also have students, so I told my student make a slide on it. It's like my inevitable step. That means 72% they just put up preprint and never published it. It never went through the filter of peer review. And preprints never were popular before COVID. So preprint space is completely unpublished. Non-peer review. So a lot of non-peer review. So in fact, Google and WhatsApp was the most common form of people getting information. The reason we were, I said, my whole predominantly was like a science communicator was because if people are relying on Google and science and this thing, then that was it. It was like telling, and some things work, but some things don't work. Narratives are built. Any other question? Yes, sir.
Question is regarding pediatric vaccination. Like most of our population is vaccinated with Covishield and Covaxin. But for 12 plus age group, we have the Corbevax vaccine, which is a protein subunit vaccine.
RBD.
Yeah. So, how do you anticipate that would fare in comparison to others? And what is the status of Covaxin in pediatric population?
So Covaxin has been approved from the ages of 5 to 18. They have done the trials. It's a field vaccine. But the Covaxin is government. The vaccine of Covaxin has two challenges. First is Sinopharm from China, this field, and India Covaxin. Both of them are field vaccines. They don't generate very robust immunity. Sinopharm is weaker than Covaxin because the adjuvant is not very strong. So to generate antibody, they are using adjuvant. So Covaxin is a better adjuvant. That's for sure. The adjuvant works much better, generating immune response. In pediatrics, the immune response other way is also very strong. So Covaxin has been tested in the pediatric. Corbevax probably is an RBD. Because of the strain biology changing, most of the research has been done on ancestral strain. Very little trials have been done using the data. We have seen virus in evolution, virus change in evolution. But probably the Omicron is very different from these strains. So the rationale for the 12 to 14 for Corbevax in the RBD is probably they believe that this should be more robust against the newer variants in the body. That is the rationale. Similarly, the Zydus vaccine is also tested for pediatric population, which is the DNA vaccine. Never got popular because 3 doses, and it has to be administered by the intradermal. It's a DBT invention. It's an Indian invention. It's a science and technology department. ESD and ESD supported. It's an excellent invention. But they also made a COVID coverage. They made a COVID coverage. They made Omisho and Tata for Omicron. Some excellent innovations are. They have not stood the test of that. So that is the rationale. That is NTAG is a very close which debates again and see what is the best bit available. They also see availability access for that. So again, it's actually the patent holder is from Texas. But they have transferred the technology free of cost to Indian Hyderabad based biological vaccine. That's where the Corbevax is made. But it's RBD, and RBD is a strong domain. I believe it's much better than even the subunit Novavax or Covax. Because subunit vaccines are the way. I personally feel nasal vaccine might have a better. Ultimately, that is the root of the. We will need polyvalent vaccines. We will need multi-strain. It will be like flu. We will probably need every 6 months or 1 year. If the virus stays, it becomes like mild cold cough flu. It's okay. We have molnupiravir or Paxlovid. Except for those vulnerable. Yeah.
My question is about post-COVID mental complications. Like, is there any scientific relevance between COVID and forgetfulness or such short-term memory loss after COVID? Because I felt the same, and when I recovered from COVID, I was facing short-term memory loss. So, actually, want to know: is there any scientific relevance, or it is just a psychological?
No, very good data. Very, very good data for long COVID. And there is I can send you an slide on UK, South Asian Professor Sarah Alan has worked on this, and two other scientists from UK who are of Indian origin who worked on it. Very clearly, forgetfulness and short-term memory loss for the first 3 months is a documented symptom of long. Only thing we need to rule out is nutrient deficiency, micronutrient deficiency. If that is ruled out, if it is persistent, then it is likely, and you need to go through a battery of tests or a counselor. The counseling is the only way you can recommend it. But if it persists, for example, the one thing which we still don't have, I still have patients who have anosmia from the first and second. And it is just, we don't have an answer for that. Similarly, for forgetfulness, if you are still forgetful, then and if you done an MRI or an neurological evaluation, it may be worth it. Usually after 3 to 6 months, it's completed. Is the observation we have had. But again, these are anecdotal. Long COVID is an area which I have worked, but not yet published. So I'll still need another 2 months to analyze the data. From home I got. Long COVID of ancestral strain, the data is fully ready for how to work as a data. Whatever little data we have, we clearly see this. Forgetfulness, short-term memory loss is a well documented. And after neurological evaluation also, most of them are normal. Most of them it is self-limiting, and most of them usually the recovery time is 6 months. Okay, but can be very debilitating, and often is labeled as psychiatric. Also, the psychiatric component comes because COVID has a degree of isolation. We are not used to staying alone, so that trauma sometimes overtakes it. And there is something called suggestiveness. When you read on Google, see nowadays what is the first human response? First human response is to go online in Google. Okay. And that's become the challenge. So that's the reason I didn't want to show slides also. I want you to talk, because if you don't talk, you don't engage. I also teach medical students. They know these talks have become irrelevant. So they get everything on YouTube. You don't engage. So the same thing. It is probably real. But many people get traumatized. And they keep on doing that again. We recommend sometimes for this cognitive behavioral therapy. See a professional counselor if it is persistent or if it is persistent out. अभी तो सब याद आता है ना. So it is a real problem. It's a very genuine real problem. And it is particularly notorious from Delta and Omicron. Any other question? Yes, sir.
I think that would be the last question now, because we are just running out.
MIS is a matter of concern in the pediatric population. So, what is the incidence of MIS or hyperimmune response following vaccination in the pediatric population?
So, after vaccination in the pediatric population, global data which is published shows that it has come down. But we didn't see a large pediatric prevalence. We had prepared a lot for the pediatric phase. We didn't see it to that extent. We had a separate pediatric dedicated task force for that, promoted it. That was active participant in that class. And pediatric vulnerable population is between, in India by law. Pediatrics is 0 to 12. Okay. In US by law, pediatrics is 0 to 18. So whatever you read in the public domain literature across the world of pediatrics is between below 18. Whatever is applicable for India is below 12. Even now the definition is still 12 by legal definition. Below 12 or below 10, in the immunodeficient states like primary immunodeficiency, you get MIS. Mumbai, Delhi, at SRCC, at various children, they have seen MIS with COVID, and they have recovered, and they have lost also. It's not unknown. Immunoglobulin is working just like antibodies. IVIG, that's the only treatment which is available. After vaccinated children in the US population, where pediatric vaccines is the most advanced, the Red Book, American Academy of Pediatric recommended, they found that the incidence is wrong. That's all I can say. Okay, but once an MI starts, it's difficult to score, but in India, we didn't see a large proportion. After Delta, across Maharashtra, we saw pediatric admission. Between the month of May of 2021 to October of 2021, we saw pediatric admission after that, when the Nucor pandemic was also. And we did see a minus. So I think Dr. Arti Kimere from BJ Medical College in Pune published this. He is active member of the pediatric task force. But as I said again, India clinicians saw a lot. I am sitting on tons of data. I don't have time to write. If there are any research volunteers who want a publication, I'll be happy to give you authorship. Even the first order also. Even if you put me in acknowledgement, it is okay. At least prepare the data and write it. I just don't have time because I have to see my patient for the end of the day. We are sitting on tons of data. And we just don't have the time. Because at the time I contacted Dr. Chavani, Dr. Chavani, he said, I will give you a statistician to sit at. But then the COVID wave was so bad that nobody could even sit at our place. But now we have the data. So, if anyone wants to volunteer, I'll be more than happy to share the data. I can ensure that it gets published in a high impact journal. We just didn't have the time. A lot of publications from India didn't happen because we didn't have resources, both in public and private sectors, to write up and collect. Also, to keep records in COVID space is very tough. We are not digitalized. See, your institute is fully digitalized, but we are not fully digitalized. You go to KM hospital, it's not easy to digitalize in COVID space that database. That's why we need to qualify. Somebody else had a question? Or we are done. Last question.
Do you see as a long COVID? Like, is vaccine going to help in a long term?
100%.
How are we going to monitor our field workers or frontliners for a long COVID? What parameters we are going to plan?
We'll get field workers or frontline workers will need vaccination every 6 months or 1 year. And one thing is very clear cut that vaccine definitely prevents long COVID based on whatever little evidence we have as of now. The level of evidence is level B, 2B. But there is level 2B evidence to show that if you are vaccinated, at least it prevents you from long COVID or delays or has a minor degree of long COVID. But that is work in progress as far as India is concerned. This data is very clear. UK data is, Israel data is also very clear. Long COVID is avoided. Maximum people and long COVID symptoms are in the older countries. So psychological problems in India tend to get often ignored. So this year's focus of government of India is mental health focus. We tend to pass it on. We just say we are tired, we don't fill up the marks. Thank you.
Thank you, Dr. Joshi, for an insightful talk. And I now request Director Madam to take a coffee table group as a moment to Dr. Joshi. Thank you all for being with us. I am extremely thankful to Dr. Gitanji Madam for her vision and support for the event. Also to the commission effort, facility staff, admin staff, accounts staff, and photography department. And thank you for all followers being with us.